let's get into some fundamentals of nursing. So, fundamentals of nursing is a very broad category. It includes everything from what we'll talk about in this PowerPoint: fluids, electrolytes, acids, bases. We'll also go over a PowerPoint that talks about vital signs and lab references, but it's just that it gives you a foundation to whenever you're moving into the other lessons throughout the course, you have that foundation of knowledge to help with understanding and to help with problem solving. Another thing that's very important in fundamentals is patient positioning. While we don't talk about it specifically in this PowerPoint, we do review it over the course with different diseases or illnesses and which positions the patient needs to be in. So whenever we're thinking of fluids and electrolytes, fluid imbalances, the most important thing to remember is that infants and older adults need to be monitored a lot more closely for fluid imbalances. Also, whenever you're thinking about dehydration, a patient with diarrhea is at the greatest risk for fluid and electrolyte imbalances. So just kind of keeping those things in mind. Infants or toddlers, pediatric population, and older patients, and then patients with diarrhea are at great risk for fluid and electrolyte imbalances. All right, so whenever there is a fluid volume deficit, there are one of three potential causes. So those are isotonic dehydration, hypertonic dehydration, and hypotonic dehydration. So isotonic dehydration is when water and electrolytes are lost in equal proportions. So they're lost equally. There's no excess of one over the other. This is seen whenever there's just an inadequate intake of fluids. Also, there can be fluid shifts between compartments within the body that can lead to isotonic dehydration. Hypertonic dehydration is when your water loss exceeds your electrolyte loss. So there is a higher concentration of electrolytes. So this occurs with things like excessive sweating, hyperventilation, ketoacidosis, diarrhea. So remember, in hypertonic dehydration, your water loss exceeds your electrolyte loss. In hypotonic dehydration, it's the opposite. So your electrolyte loss exceeds your water loss. You have a higher concentration of water. So some possible causes are excessive fluid replacement, kidney disease, chronic malnutrition. So it's important to recognize the differences in the water and electrolyte balances with each of the three different types of dehydration. All right, so let's get into some lab values. So a normal potassium is 3.5 to 5. So that would mean that hypokalemia, the low potassium level, is anything less than 3.5, and hyperkalemia is anything greater than 5. So with hypokalemia, your EKG is going to show an ST depression, some shallow, flat, or inverted T waves, maybe some U waves. And then for potassium replacement, any potassium replacement, it may cause nausea, vomiting, and it should not be taken on an empty stomach because of the GI upset that it can cause. In comparison to that, when you have hyperkalemia, potassium greater than 5, your EKG is going to show tall, peaked T waves, a widened QRS, and flat P waves. There are early signs and late signs of hyperkalemia. Your early signs are muscle twitches, cramps, paresthesias, whereas your late signs, you're going to have profound muscle weakness, kind of just flaccid paralysis for the late signs. So with the potassium imbalances, as well as the calcium and phosphate and sodium, all the imbalances we'll go over, it is very important to memorize the EKG changes that come along with that. You will very frequently see those on the NCLEX. So just to reiterate, a patient with hypokalemia will have ST depression on their EKG, shallow, flat, or inverted T waves, as opposed to a patient with hyperkalemia, which will have tall, peaked T waves, a widened QRS, and flat P waves. So most often they're going to ask about those T waves, but definitely know the differences. Now, during a potassium infusion, if you're giving potassium inpatient, you're never going to give potassium via IV push, sub-Q, or IM. So potassium should always be given with an infusion device. The patient should always be on a cardiac monitor just because of the close relationship between potassium and cardiac dysrhythmias. And the reason for this is that the reason it's never given IV push is that it may cause phlebitis or inflammation of the veins. Also, it's very important to assess kidney function before, during, and after administration of potassium to make sure that they can excrete and process things like they should be. Another thing to think about is that GI fluids are very high in potassium. So if someone is receiving GI suction, whether it's through a nasogastric tube or whatever it may be, they are at risk for hypokalemia, because if that suction is suctioning out a lot of their GI fluids that are high in potassium, they're going to lose potassium that way. So that patient will be at risk for hypokalemia. Okay, so our normal sodium level is 135 to 145, making hyponatremia less than 135 and hypernatremia greater than 145. Hyponatremia, you are going to see diminished deep tendon reflexes, increased urinary output. If a patient is taking lithium, you need to closely monitor the lithium levels because hyponatremia can cause diminished lithium excretion, resulting in lithium toxicity. So it's very important to remember that if a patient is hyponatremic and they take lithium, you need to monitor the lithium level because hyponatremia, again, can cause diminished lithium excretion, therefore leading to lithium toxicity. With hypernatremia, the patient may experience extreme thirst. They're going to have decreased urine output and an increased urine-specific gravity because the urine that they do put out is going to be a lot more concentrated. All right, so our normal calcium levels is 9 to 10.5, making hypocalcemia anything less than 9, and then hypercalcemia anything greater than 10.5. So for hypocalcemia, low calcium, you're going to have a decreased heart rate, decreased blood pressure, diminished pulses. You're going to have muscle cramps, tetany, seizures. Just think of like cramping, tightening up of the muscles. This is where you're going to see your positive Trousseau's and Chesavox sign. You're going to have some cramping, diarrhea. And then again, on the EKG, you will have some prolonged ST and QT intervals. Now, with hypocalcemia and the positive Trousseau's and positive Chesavox sign, your Trousseau sign, so what that is basically involuntary contraction of the muscles of the hands and wrist. So when an examiner would inflate a blood pressure cuff on the upper arm, and then a carpal spasm would occur with inflation of the blood pressure cuff. So it's that involuntary spasm and contraction of the hands and wrist. And then the Chesavox sign is basically a twitch of the facial muscles that occur when gently tapping the patient's cheek. So both of those are very characteristic of hypocalcemia. As opposed to hypercalcemia, you're going to have an increased heart rate, blood pressure, kind of bounding pulses. You're going to have severe muscle weakness, diminished reflexes, lethargy, coma, constipation, and instead of the prolonged ST intervals, you're going to have a shortened ST segment. So definitely know both, but if you only know the characteristics associated with hypo or hyper, you can flip those for the other because they're inverse, they're opposite. And then, of course, a patient with a calcium imbalance is always going to be at risk for fractures. So you want to move them very carefully and slowly with positioning and things like that. All right, magnesium. A normal magnesium level is 1.8 to 2.6, making a hypomagnesemia less than 1.8, and then a high magnesium greater than 2.6. So with hypomagnesemia, It's a hard word to say. You're going to have the increased heart rate and blood pressure. Again, you're going to have the positive Trousseau's and Chekovec sign. You're going to have that hyperreflexia, the seizures, tall T waves, and depressed ST segments. Whereas with your high magnesium levels, you're going to have the decreased heart rate and BP. You're going to have the opposite, the muscle weakness and diminished reflexes, the lethargy, coma, and then the widened QRS and prolonged PR interval on an EKG. Very, very important to know the antidote for magnesium. So the antidote for magnesium overdose is calcium gluconate. Okay, so definitely know that calcium gluconate is the antidote for a magnesium overdose. You also want to avoid the use of laxatives and antacids because those contain magnesium as well. So the most important thing to remember from this slide is that calcium gluconate is the antidote for a magnesium overdose. So a question on the NCLEX may describe a patient coming in that has a decreased heart rate and blood pressure. They have muscle weakness, they're very lethargic, they have a widened QRS on their EKG, and their magnesium level is 2.9. What is going to be the anticipated treatment for this patient? And calcium, you would recognize those symptoms and that lab value as a high magnesium, and then you would know that calcium gluconate would be your treatment choice because it's the antidote for a magnesium overdose. All right, so when we're thinking of phosphate, a normal phosphate is 3 to 4.5. So low phosphate less than 3, high phosphate greater than 4.5. So phosphorus and calcium have an inverse relationship. So a decrease in phosphate is accompanied by an increase in calcium. And then an increase in phosphate is accompanied by a decrease in calcium. So if you can remember they have an inverse relationship, it'll all definitely help on the NCLEX because you will be able to sometimes rule out or rule in answer options based on the phosphorus and calcium levels. So with a low phosphorus, less than 3, you are going to have decreased reflexes, diminished pulses, seizures, increased breathing. And then with a high phosphorus, the side effects that occur are mainly secondary to hypocalcemia. So you'll go back to those hypocalcemia, the assessment findings for hypocalcemia, and you will see those in the high phosphate. So of course, you're going to monitor for signs of fracture with the calcium imbalances. And then again, you want to avoid laxatives and enemas because these medications contain phosphates as well. So you will avoid laxatives and enemas in a patient with an elevated phosphate level. So the carbonic acid bicarbonate system is the primary buffer system in the body. It maintains the pH of 7.4. And then specifically with a ratio of 20:1, with 20 parts bicarbonate, 1 part carbonic acid. It's controlled by the excretion of CO2 in the lungs, so the rate and depth of respirations change in response to changes in the CO2. So that brings us into acidosis versus alkalosis. And so with acidosis and alkalosis, you can have a respiratory etiology or a metabolic etiology. So you can have respiratory acidosis or respiratory alkalosis, and then metabolic acidosis and metabolic alkalosis. So there are some primary principles we'll go over. That way it'll teach you how to read an ABG or an arterial blood gas. So with acidosis, it's acidic, so your pH decreases. Whenever the pH decreases, your respiratory rate and depth increase in an attempt to exhale the excess acid. Your potassium level will increase as well in acidosis. Whereas in alkalosis, it's basic, so your pH level increases, and then your respiratory rate and depth will decrease. So the CO2 is retained, and then the carbonic acid increases, therefore decreasing the pH to a more acidic value. So, and then in alkalosis, your potassium levels decrease. So, acidosis, your pH decreases. Alkalosis, your pH increases. So, in respiratory imbalances, there's an opposite relationship between the pH and the CO2. Whereas in metabolic imbalances, there's a corresponding relationship between pH and CO3. So, for example, in respiratory acidosis, the pH is decreased because it's acidosis, so the pH is decreased, and we know that in respiratory imbalances, there's an opposite relationship between pH and CO2. So respiratory acidosis, our pH is decreased, so we know that our CO2 is going to be elevated. So respiratory acidosis is caused by any obstruction of the airway that can lead to hypoventilation or any illnesses that depress the respiratory system, such as asthma, COPD, emphysema, brain trauma. Those are all good examples. Now, in respiratory alkalosis, it's alkalosis, so we know that our pH level is going to be increased, and we know that in respiratory imbalances, there is an opposite relationship. So if our pH is increased, our CO2 is decreased. Okay, so it can be caused by conditions that overstimulate the respiratory system, such as hyperventilation or severe anxiety. Kind of flipping over to metabolic, we know that in metabolic imbalances, there's a corresponding relationship between pH and CO3. So in metabolic acidosis, we know it's acidosis, so we know the pH is decreased. Since we know there's that corresponding relationship, we also know that the CO3 is decreased. And then metabolic alkalosis, the pH is increased, and then the CO2 is increased as well. Now, with metabolic acidosis, can also be known as diabetic ketoacidosis. So an insufficient supply of insulin to a patient with diabetes can result in metabolic acidosis. Also, it can be caused by severe diarrhea, which can cause that electrolyte imbalance. Metabolic alkalosis, you want to monitor the patient with excessive vomiting or GI suctioning for signs of metabolic alkalosis. So, moving forward, we can, whenever we're looking at ABGs or arterial blood gases, because the NCLEX is likely to give you a question that says, and I'll go ahead to that. These are your normal ABG values, and definitely memorize these. The NCLEX will give you a question kind of listing these values, and then they're going to want you to determine if the patient is in if it's a respiratory or metabolic imbalance, and then if they're in alkalosis or acidosis. So when you're analyzing ABG results, you determine if the pH is elevated or decreased. That will determine if you have acidosis versus alkalosis. Then you want to look at the CO2. If the CO2 is opposite the pH, you know that the condition is respiratory. And then you look at the CO3, and if the CO3 has a corresponding relationship with the pH, then you know it's a metabolic imbalance. So just remember, low pH for acidosis and high pH for alkalosis. A respiratory imbalance is going to have an opposite relationship, whereas a metabolic imbalance is going to have a corresponding relationship. So if you memorize those, definitely memorize these lab values. You will be able to read and analyze any ABG that's given to you. Let's go back to this last slide. So prior to drawing an ABG, you always want to perform an Allen's test. So an Allen's test is when the examiner or the person drawing the ABG will apply pressure to both the ulnar and radial arteries at the same time. You then ask the patient to open and close the hand rapidly. You release pressure from the ulnar artery while compressing the radial artery, and then assess the color of the extremity distal to the pressure points. So there should be return of normal color with one artery occluded. You just want to make sure they're getting very good blood flow through the hand before you perform that ABG. And then after the ABG is performed, you want to maintain pressure to the puncture site for 5 to 10 minutes to reduce risk for hematoma.